Kia ora. Welcome to a brief overview of clinical presentation and some of the ECG variances that we might expect in a pregnant patient. I'm not going to go through all the changes that happen in terms of anatomy and physiology in pregnancy. You can certainly go back and review your notes from human body system study that will cover these in detail. Instead, we're going to focus firstly on the types of cardiac issues that are likely to complicate pregnancy. Cardiac issues, in fact, are the second highest cause of maternal death. And the most common causes of maternal cardiovascular morbidity are associated with cardiomyopathies, ischemia, arrhythmia, valve disease, and aortic dissections. From a medical perspective, you could think that cardiovascular challenges fall into two groups. The first is the patients that have known cardiovascular problems for whom the anatomical and physiological changes in pregnancy will exacerbate the existing issue. The most common reason for the cardiovascular presentation is going to be an existing myopathy. So this is a structural heart disease. It may be congenital, it may be acquired, it may affect the contractile units, it may affect the valves, but essentially it's going to be a structural disease. One of the more common causes of valvular dysfunction during pregnancy is a history of previous inflammatory disease, such as a childhood rheumatic heart disease that's resulted in this valvular failure. The predominant symptomology for structural heart disease is going to be the onset of heart failure type symptoms, and in serious cases this can progress to cardiogenic shock. So typically, as we'd expect with heart failure, at one end of the spectrum we can see people with fatigue and a degree of exercise intolerance, and as the problem worsens we see the formation of edema, and if it's associated with the left ventricle we're going to see acute shortness of breath coupled with acute cardiogenic pulmonary edema. In the case of a mitral valve lesion, arrhythmias quite often are coupled with the structural defects, and atrial fibrillation would not be an unexpected finding. The second group that we consider are those who develop cardiogenic symptoms in the absence of previously identified cardiac issues. And this quite often unmasks patients who've had undiagnosed coronary or ischemic heart disease, and the physiological changes in pregnancy are going to make this symptomatic. So for those that have ischemic presentations, the cardiovascular risk factors are very similar for those of the general population, but there's a threefold increase in risk during the pregnancy. The ischemic symptoms are still likely to be based around chest pain, and this may be due to coronary artery insufficiency, or it might be secondary to a tachycardia with poor ventricular filling times. In patients with undifferentiated pain who are pregnant, it's really important to go through both the modifiable and non-modifiable risk factors of cardiovascular disease. Finding about these should lower suspicion for doing ECGs and recommending ED reviews on the basis that there could be cardiogenic problems. The normal variances in the ECG of the pregnant patient will include left axis deviation. Now this is probably due to the slightly upward and leftward displacement of the apex as the diaphragm rises. These deviations and the increased diastolic filling volumes may promote a sagging appearance of the ST segments. And in the more right-sided leads, such as 3, we may see a flattening of the T waves and the appearance of Q waves in the inferior leads. And in terms of a clinical gem associated with this, we don't go to too many pregnant patients that require an ECG. And should the suspicion be there that requires an ECG, there's a very high probability that further assessment will be of benefit to the patient. Ka kite.